Uh, so I'd like to welcome everybody to Pediatric Grand Rounds. Just a little bit of housekeeping. If I could remind folks to please fill out the CME information on the invitation to the Zoom meeting in the email. That helps us track attendance, even if you're not claiming CME. It's very beneficial for continuing this programming. In addition to the technical support, hopefully in the future, we'll be able to eat meals again at Grand Rounds. So every accounting of attendance would be much appreciated. So today it's my pleasure to introduce Dr. Martin Olsen. Dr. Olsen started his medical career at the Medical College of Ohio in Toledo, Ohio. He went on to complete a family practice residency in Akron and completed a year of fellowship in OB, also in Akron, before going to Chattanooga and completing an OB-GYN residency. He joined us here at Quillen in 1992, Dr. Olsen?
That's right. Been a while.
Were you one of the initial faculty members, or was that right after the school was founded?
Well, I think the school's about under 10 years old, so I've only taught about 80% of the graduates.
That's great. So Dr. Olsen has served in many roles here at ETSU. He's been chair of the Department of OB-GYN. He's been their program director. He's also served as the chair of the state ACOG, Cincy ACOG. Dr. Olsen has appeared in many media modalities, including as a columnist in the Johnson City Press, and he's had a run for the United States Congress. He has numerous publications. Many of the more recent ones are focused on treatment and prevention of neonatal abstinence syndrome. And for the past several years, he's led the initiative here within the university for prevention of NAS. And I think any of us who have worked in the newborn nursery or in the NICU have seen many of the positive impacts he's had on our patients and our families. So I know it's an area of great advocacy and he's had some success, but there's a lot of work left to be done. So I'll turn it over to Dr. Olsen to tell us about some of it.
Well, thank you so much for inviting me today. And to start things off, I've got a brief video clip which discusses history of addiction in America.
You know, if you were to follow a busy doctor as he makes his daily round of calls, you'd find yourself having a mighty busy time keeping up with him. Time out for many men of medicine usually means just long enough to enjoy a cigarette. And because they know what a pleasure it is to smoke a mild, good-tasting cigarette, they're particular about the brand they choose. In a repeated national survey, doctors in all branches of medicine, doctors in all parts of the country were asked, "What cigarette do you smoke, doctor?" Once again, the brand named most was Camel. Yes, according to this repeated nationwide survey, more doctors smoke Camels than any other cigarette. Why not change to Camels for the next 30 days and see what a difference it makes in your smoking enjoyment? See how Camels agree with your throat. See how mild and good tasting a cigarette can be.
We're going to come back to that video a couple of times, but first let's talk about two different patients. Patient number one is a pilot. He's a male. It's discovered that he's addicted to buprenorphine, Suboxone, Subutex. And he goes to his addiction medicine specialist and he said, listen, you've got two options. Option one is you can start taking buprenorphine prescribed, take it as long as you want, take it the rest of your life, but you'll never fly again because you can't fly when you're on that. Or option two, if you are well motivated, well, then we can get you off this medication. Well, the pilot decides he's motivated. He wants to work. He decides to come off. Patient number two is pregnant, which of course means she's a woman. And she goes to her addiction medicine specialist and she says, I'm motivated. I want my baby to be born without drug withdrawal. I want to come off this stuff. And the standard of care in the United States today is the doctor says, sorry, sweetie, that's too dangerous. I'm going to admit something about this video. I had lots of clips I could have picked. I picked the most sexist one I could find because I think we should ask the question, why is it in the year 2021, a group of predominantly male patients has more options than a group of 100% female patients. So we're going to talk about NAS prevention today, and we are going to confront much dogma in addiction management in America. And for questions, we'll have 2 breaks and then questions at the end. Miranda, if you want to wave at everybody, Miranda, so they know you really exist. Thank you. So just text or just use the Zoom comment feature. Miranda will text me. And just housekeeping on terminology. There's a growing desire to use the term NALS, neonatal opioid withdrawal syndrome, instead of NAS. I personally feel that NALS is incomplete. NAS is caused by many medications, including opioids, but also including benzodiazepines, also including gabapentin, also including SSRIs. So I think it's an incomplete term, but predominantly the state of Tennessee tracks NAS. I need to talk about a disease that I can use state of Tennessee statistics for. And so since the state of Tennessee goes with NAS, I'm going with NAS too. And we've got 3 components of the talk today. It's sort of a how we got here, the history of the rapidly rise of neonatal abstinence syndrome, and then why we need to change the way we do things in the United States. And then finally, how to prevent NAS. If the patient shows up and says, I don't want a baby with drug withdrawal, how can we get her there? So this is NAS in the United States, most recent data. Here's Tennessee, of course. Note the Appalachian corridor of NAS. And note this number down here. You get to be the worst, among the worst, if you have 12 patients out of 1,000 with NAS, or 1.2%. Well, look how bad we are, but it's actually worse. So this is for Tennessee, breaking it down. Northeast, that's us. 38 per, so we're more than 3 times as bad as the state data. Go next door to Sullivan County, 52, 5%, more than 4 times as bad as the state data. So Sullivan County, it's 5% of babies are born with NAS. And for our patient population, it's similar to that. So Johnson City is worse than the rest of the Northeast. I put this slide of West Virginia up here for a couple reasons. Number one, this entire state is as bad as we are in the worst part of our state. So there's a whole state that's as bad as we are, 5%. But look at this, 143 per 1,000 opiate exposed newborns. You know, some data will say less than 50-50 of the babies have NAS, some say more. This was 19,000 patients. That's pretty good data. So when we talk about NAS, we're talking about perhaps half or perhaps even only a third of the overall burden of opiate exposed newborns. So they are the cases we first identify, but these young folks are going to have problems potentially throughout their childhood or even lifelong. So we need to think about the entire burden of opiate exposed newborns, not just NAS. And please remember this, what causes NAS? It is buprenorphine, Suboxone, Subutex. So here's state of Tennessee data. Numbers add up to more than 100 because of polypharmacy. Medication-assisted therapy prescribed, almost 2/3. Non-opioid prescription obtained without a prescription. Prescription without prescription, another 30%. So for East Tennessee, it's about 90% is either prescribed or street Suboxone or Subutex. What causes NAS? Buprenorphine. Our policymakers don't tend to understand that. And that gets back to, I think, that Appalachian corridor. If you're at one of the 25 major medical schools in the United States writing papers, you don't live in the Appalachian corridor. You live in a big city where fentanyl and heroin are the problems. Well, in our case, it's buprenorphine. So it's okay for us, in my opinion, to have a different strategy because we have a different drug. This is our local data. Here again, buprenorphine is the drug, almost as much buprenorphine as marijuana. Benzodiazepines, number 3, and that's written by the same people that write for the buprenorphine. So medication-assisted therapy. Now, as a clinician, when it seemed like all of a sudden one day we woke up and where all these opioid addicted patients come from, it just seemed like it was all of a sudden. And if you look at the years of rise, it actually was really quick. Here's 2008, Tennessee. We're among the best. We're doing great. Well, we go into 2010. Yeah, we're getting a little bit worse, and some others are getting worse too. And yeah, we're a little worse than 11, and we're a little worse than 13, and 14. We're as bad as anybody. But look, well, there are some states around us that never got worse. We went from among the best to among the worst in 7 reporting cycles. Well, what could have caused that? Oh, look, buprenorphine went up by 2.5 times. And here it is, just to put it in a line so we can really see it. Look at our blue line here. More buprenorphine, more NAS. Now, I can imagine a public health official saying, it's unfortunate that so many babies are having this, but we're saving lives with buprenorphine, and sometimes there's unintended consequences. So let's look at that. Are we saving lives with buprenorphine? Same time interval. No, we are not. This number should be going down with more buprenorphine. It's actually went up a little bit. So there is a concept of what is the right amount of a drug. What is the right amount of anything? So it's called the inverted U concept. So let me explain the inverted U concept. And we're going to use well-adjusted children because I'm talking to pediatricians here. So if a family is in poverty, it's hard to raise a well-adjusted child because they've got food shortages, they may have shelter issues. It's just so much crisis going on. It's hard to have well-adjusted kids. But interestingly, if the family is incredibly wealthy, they have problems raising well-adjusted kids because now they've got stressors based on all that income. Now they've got risk of exploitation. So it's actually hard to raise well-adjusted children for billionaires. The sweet spot's the middle class. So the right amount of economic support is middle class if your goal is to raise well-adjusted children. That's where you want to be. And for opioids, you don't have enough opioids, you got a lot of pain and suffering. You got too much, you got an opioid epidemic. You got the right amount, you're improving quality of life. So the concept that I'd like folks to remember on buprenorphine, it's not a good drug, it's not a bad drug, it's a drug with a proper role. It has saved patients' lives, but there's such a thing as too much. And we have too much buprenorphine in our state. We have too much in our communities, and our individual patients, we'll talk later, are being prescribed too much. So there is a proper amount, and this certainly goes, the American Society of Addiction Medicine and the buprenorphine manufacturers would not agree with me. They will say things like, put it on every street corner, pass it out. And again, they claim to be saving lives, but let's look. More buprenorphine, more NAS, without a positive impact on saving lives. So there's a right amount. Let's talk about this drug buprenorphine. Very potent, 30 times as potent as morphine. So Lortab's 1-to-1. So for comparison purposes, I talk to patients about, ma'am, I see you're on 16 milligrams of buprenorphine, and that is the dose that is recommended by the manufacturer. It's the most commonly prescribed dose here. And I explain to the patient that she's on the equivalent of 48 Lortab 10s a day. And real patients will come see me and they'll be abusing 6 Percocet 10s a day. Percocet's 1.5. So that adds up to 90 morphine equivalents or 3 milligrams. That would have been the proper dose, but they went to one of the office-based opioid treatment centers and were placed on 16. So now they're on 480 morphine equivalents. So I can't get them down to the dose that they were on when they started because we don't have enough time to get it done. So there's a right amount of buprenorphine for a community. There's a right amount for an individual patient. Just to remind everybody that 2 different, these are the names by the manufacturer. Subutex is buprenorphine alone, also called buprenorphine monotherapy. Suboxone is buprenorphine plus naloxone. Subutex is more likely to be diverted than Suboxone. The manufacturer believes Suboxone is safer than Subutex. They did just pay a large multi-million-dollar court case loss because they overstated its safety. So I write for either one. The ACOG guidelines say write for Subutex, not Suboxone. And there is some logic to that. Logic is that, well, if you can get it done with one drug, get done with one drug instead of two. But in reality, for the doctors in the trenches, patients are at risk of domestic violence. Subutex is a more valuable drug than Suboxone. They're more likely to be abused, have their medication stolen, divert it to their partners. So we use both. So some more information about buprenorphine diversion. Patients snort it, smoke it, inject it. The official statement from the American Society of Addiction Medicine is it's just a medication to get rid of cravings. It has nothing to do with, doesn't make you feel anything. So if that were the case, why would somebody snort it, smoke it, and inject it? I brought my prop here. So locally, if you want to inject your Subutex or Suboxone, you'll mix it in Mountain Dew, and then that's what you would inject. These drugs have street names. Suboxone is Box, Subutex is Tech, and buprenorphine is the #1 non-cannabis drug seized by the Tennessee Bureau of Investigation. So it is the #1 drug in jails. It is a gateway drug. Patients will tell me it's the only non-cannabis drug they've ever taken. So I wanted to just finish up with Dr. Campbell here. So if we think about the history of addiction in America, more recently the opioid addiction, the American Pain Society decided in the 90s that no patient should have pain. So doctors were bad doctors if their patients had pain. The Joint Commission of Hospitals agreed. You've seen the little smiley faces, frowny faces in the hospital. They date from that era. And doctors wrote for more opioids. Well, it turned out that the American Pain Society was getting significant funding, and the leadership were getting to take nice trips or getting grants or getting speaking fees for promoting that idea, to the point that the American Pain Society is now out of business. They could not defend themselves from all the lawsuits for starting the opioid epidemic. So that's how we got there. And I would say, if you look at the curve for the NAS epidemic, guess what? We've done it again. Dr. Campbell makes a couple more points. This ad was found in publications like the Journal of the American Medical Association. So this was not a couple of rogue doctors making commercials. Organized medicine made more money from cigarette ads than it did from dues during that time period. So organized medicine's been making money from addiction for 70 years. So I think it's okay for us to look at anything about addiction and say, let's follow the dollars. And finally, if you think of life from the view of a patient, imagine a patient, she's been injured. She then goes to her doctor, she gets put on pain medication, she becomes addicted. Well, after a while, the doctor says, you're addicted, I'm not treating you anymore. So she goes to the ER. They say, you're an addict, get out of my ER. So she goes to a local for-profit office-based opioid treatment center, and they say, hey, glad to meet you, $100 a week. Well, by the time she comes to see me, she doesn't really trust doctors very much, and I don't blame her. So it sometimes takes us a long time to build trust with these patients. And I think they deserve that time, because we have to remember, to us, or to them rather, some of us look just like Dr. Campbell, and they don't trust us. We have to earn it. So this is question break number 1. So let me see if Miranda sent me any text here yet. And apparently not yet. All right, so we'll go on to the next part. So this is our current standard for the treatment of addiction in pregnancy. And we're going to discuss some areas that I think are outdated. This is a document that, in my opinion, needs to change dramatically. So NAS is easily treated. That's the NAS so what argument. Tapering provokes relapse. Tapering doesn't even work. So let's address some of those. So NAS easily treated. And that's exactly, NAS is an easily treatable disease. The implication being, why would we even bother working with this when we're confronting an easily treated disease? So these babies, of course, are in the newborn intensive care unit. There's a death rate. It's very low, well under 1%. It is not zero. But so we lose patients to NAS. The cost in our state for each NAS baby is $43,000 more than the average cost. But to me, most concerning are the long-term school performance issues. You remember that West Virginia data, 15%. That means every first grade teacher's got 3, maybe even 4 kids in her class that are NAS exposed. In our own community, they've got special programs for NAS exposed. And when I talk to teachers and say, the experts say that NAS has no long-term consequences, they are appalled. Let's look at the data here. This one, MRIs show that there's less gray matter, less white matter in an NAS baby compared to a non-opiate exposed newborn. This one, Tennessee children, long-term consequences. Towers, the person who started the tapering from Knoxville, their heads are smaller. Get out your tape measure, their heads are smaller. This one, 1992. So we've known this for a long time. But this is from 2019. This is American Journal of Obstetrics and Gynecology. Studies that examine development. I cut it out because I wanted to make sure you knew that this is exactly what they're saying. Have demonstrated minimal to no long-term neurodevelopmental impact. So this is the official standard. You know, there's a bunch that's not mentioned in this. Pediatricians. So I will ask you to consider the fact that obstetric leaders are passing 10% of babies on to you in our region that have potential for long-term cognitive deficits. And the national leaders have done nothing to confront the leaders of my specialty. Now, if we go back 15, 20 years, there was the Group B strep controversy, and obstetricians, and I was one of them, said, listen, we're not putting our mothers at risk for GBS. And the pediatricians said, let's talk about this. And there was a dialogue and changes occurred. So I am speaking at the virtual ACOG meeting on this topic. Thank you for letting me practice today, by the way. Whether more than 5 people tune in, I don't know. But if there's anything any of you can do to wake up your national pediatric leaders, I would suggest that you do so, because every first grade teacher in Johnson City has got 2 or 3 of these kids in her class on average. And keep doing what we're doing, to me, is just not acceptable. Now, relapse, this is something that deserves a lot of discussion. And let's look at life from a patient's view. Either A, she's going to come off someday, or B, she's going to stay on the rest of her life. So perhaps you pick the time when the patient's most motivated for her to come off if she plans on coming off at some point in her life. Medical students will tell me they're being taught that patients on buprenorphine should stay there the rest of their lives. And keep in mind, just in doctor's fees, that's about $300,000 for that patient. The house she'll never have, the college tuition she'll never be able to save for her kids. But take a look at this article down here. If there are opioids prescriptions and they count buprenorphine in this article, in the home, the risk of suicide in children goes up. So this concept to just leave people on buprenorphine the rest of their lives has contributed to NAS, and it's probably going to contribute to adolescent suicide. And in the principle of justice, you don't take care of one group while you put another group at risk. So relapse is a part of addiction. Relapse occurs. Relapse, overdose, death, horrible, horrible. But most addicted patients relapse, and it's a part of disease management. Here is the one study on relapse in pregnancy that's in print. 20% were lost to follow-up, 45% had relapsed, defined by presence of other drugs in their urine drug screens. That makes 65% had a negative outcome. And to me, this is an argument to take a look and do things differently, not an argument to keep doing what we're doing. Our relapse study, our data is in, we're starting to analyze it. The preliminary review, and we compared patients followed in our tapering clinic versus patients followed by some of the outlying office-based opioid treatment centers. the relapse rate appears to be similar. So there is no evidence that tapering programs put the mothers at risk. Now, theoretically, the risk is horrible. And I'm practicing in Johnson City, Tennessee, where the drug is Suboxone. If my colleagues are practicing in Nashville, where the drugs are fentanyl and heroin, the rules might be different. So we talk about relapse a lot to our patients. It can certainly be life-threatening if the patient takes an opioid that is associated with overdose and death. But in our region, we've got Subutex, Suboxone. People don't die from that for the most part. It's very important the patient is comfortable reporting relapse. The rule is you never get mad at a patient for telling you the truth. So have you had relapse? She tells us. And the question then is, what did you learn to prevent the next relapse? Now we're going to talk about the relapse doesn't work argument. There are multiple papers showing that relapse doesn't work, with major problems with the vast majority of them, because they don't even tell you what they taper down to. They just say, we tried, it didn't work. There are two good papers. By good, I mean they give you the data. You can interpret it yourself. Here's one of them. The two papers are very similar. They tapered all the way down to 15 milligrams. They tapered down to 45 Lortab 10s a day in the equivalent, with a standard deviation of 6. So that was their mean. Here's our bell-shaped curve. You should note that 8 is the highest dose we will write for. We won't write for anything higher than 8. So 87% of their study was at doses higher than we ever write for. We try to get people down to 2 milligrams. So we're down here at the 2 percentile or less range. So 98% of their study was at above levels. And remember, 2 is still 60 morphine equivalents. It's not a teeny tiny dose. So I would say that this has not yet been studied. And it's another one of our studies that data collection is winding up, and hopefully we'll have some information to share in the future. Now we do have a study on those who come off completely. So the good news is, and this isn't rocket science, but it appears to be news, that if a patient comes off drugs completely, then the baby does not have NAS. And our success rate in getting people off completely is not high. So those that are opponents of tapering would say, well, listen here, Dr. Olsen, you got 5% of your patients off. I mean, that's a waste of time. Well, 5% is higher than 0. And the onus is on us to figure out how to do it better. So NAS rate is 0. Now, we reviewed all 200 patients at that time that had participated in our program in any way, because we wanted to find if we were hurting patients. And, it's not as scientific as we'd like, because there's not a reporting system. If my patient goes to Ohio and gets hit by a car and I never see her again, there may be no way I'll ever know. Patients do not lose their rights to privacy when they die, so we don't get a report. So as far as we can tell, for these 200 patients, we did have some bad outcomes, and you got 200 high-risk patients. If I didn't say we had some bad outcomes, you'd know I was lying to you. So we did have one patient who had an abruption, and she had a history of abruption, and she was already off the medication. So it was our determination that it was the abruption that caused it, not the fact that she had been tapered several weeks ago. And then there was one mother who had a death. It was, and I can't tell you what it was. It had nothing to do with her pregnancy. It had nothing to do with her opioid addiction. And it is in the top several, if you were to pull the list of reasons why young people die, it's in that top area. And again, not related to pregnancy or MAT. So it is my contention that had nothing to do with our program. So we have, as far as we can tell, we have not hurt any mothers, and NAS is preventable. I'm going to pull, this is part 2 question time. So let's see if we got anything new on here from Miranda. Still no question. Well, either I'm brilliant or I'm stunning you, one or the other. All right, the final portion here is how our program works. And we have to recognize that there are multiple reasons why a patient might one might say she wants to participate in our program. So the best reason, of course, is she really wants to do what's best for her baby. She wants a baby that doesn't have neonatal abstinence syndrome when it's born. But there are other reasons. So in our community, it is common that the physician will write for more than the patient needs. The patient will sell some. So she gets a prescription for 16 milligrams. She sells one pill. She takes one pill. She's got money to come back to the clinic next month. And I've heard this from medical students that the system is explained to them by the attending physician. Patients will tell me they went into the clinic and said, I think I need 4 milligrams. Well, here's your prescription for 16. So patients they're tired of that. That's one reason why they might switch to a program that says, we're going to work with you to get your dose low. Patient, the street Suboxone use is significant. And if a patient's getting Suboxone off the street and she has a urine drug screen when she delivers that says Suboxone without a prescription, well, then now she has an addiction problem and she's going to be a target of a Department of Human Services. Or if she has a prescription, she has some attention, but it's significantly less. So they may come just to get a prescription. Or they may be trying to hold a secret. They know if their baby goes to the newborn intensive care unit, their family's going to say, what happened? And the family would then know that they're addicted. So they want to get off to avoid that confrontation with family, or they may have family pressure. So the challenge that we provide in the care have is that we've got all these other reasons why people might come to see us, and we have to develop trust. We have to bring them up to the first reason. And I think we have some significant success with that. And it is common that it takes multiple visits until we get there. And with some patients, we never get there. But still, there's lots of reasons. You have to get where the patient lives. And there are neurons synapsing for mothers that they want their babies to do well. So we assume that that's what they want. We recognize that there's these other components. So what does the patient need to do to have a baby that does not have NAS? Well, we try to get her off before delivery, 34 weeks before. And the thinking being that patients will tell me that it takes about 3 weeks for them to adjust to a taper. So if they're off at 34 weeks, then by 37 weeks, it's completely out of the fetus's system and the fetus shouldn't have NAS. In our study, there were quite a few patients that didn't come off to 36, 37 weeks. Their babies still did not have NAS. We keep tracking their urine drug screens after they're off. And then, of course, from the patient's view, it's got to be negative time of admission. Cord stats are done by all of you, but I'm not sure that if you got a negative UDS, that's necessary. The reason is there were 4 patients. They weren't included in the data because 4 is not enough to make a conclusion, but 4 patients had negative drug screens, positive cord stats, and 0 NAS. So that's just an area of further attention. So in terms of how, one thing I would ask from your department is to design some criteria so I can tell the patient, do this and you won't have to stay for 5 days. And in the past, if a patient had 5 negative drug screens, and that included the hospital screen, then the decision was made that you're off and your baby can go home just like all the other newborns. And then that happened the last time we had a patient too. So that's the way it usually happens. But every now and then there'll be a patient that will have negative drug screens and she's told, nope, sorry, you need to stay 5 days. When you look at life from a patient, the concept of I am a good mom, I am now a normal patient is very important in making progress for the future. And so I would ask you to consider a policy so the patient knows, do this and your baby can go home, because that patient feels pride in herself and it helps her become a good mom, in my opinion, when she can say, I did this and my baby is now being treated like every other baby. Other things we do with our patients, she's got a desire to taper. And we have 2 groups of patients in our we have in our department, we have the patients that want to taper, and they work with myself and Dr. Murphy. We have the patients that say, I'm happy where I'm at, and we tell them about it, and they keep doing what they've been doing. It's less than 50% decide to taper. And patients have rights and autonomy, and that's a standard of care in America. We would not want to make that patient feel bad. But if the patient desires to taper, she signs the agreement. She knows that if she wants to change her mind and go back to her other prescriber, nobody gets mad. It's autonomy. We'll still take care of her during her pregnancy. The starting buprenorphine dose is sometimes a difficult discussion because patients will not take the same amount of street drugs every day. So we'll do a morphine equivalent calculation. Most patients are already on Suboxone, so that makes it easy. I'm on a quarter box a day, means I am on 1/4 of an 8 milligram Suboxone pill or 2 milligrams. So if the patient says I'm on a quarter box a day, we write for 2 milligrams. But some patients will be on a little bit of this, a little bit of that, a little bit of something else, and it's hard to figure out exactly what the dose is. So we'll make a rough calculation. If it's somewhere between 4 and 6, probably go with 6 because I want the patient to succeed. Patients will lie. They will lie and say they're on higher doses than they're on so that I'll write for more medication so they can then sell some. Patients will lie and say they're on lower doses than they're really on because they want me to like them, and they're afraid if they tell me the truth that I won't take care of them. And all the talking in the world doesn't overcome some of that negativity they've had with the healthcare system in the past. So this is an early challenging decision to make at times, and we do the best we can. We see the patients as soon as we can, just to make sure it's the right dose. We don't write for more than 8 milligrams, and physiologically, up to 4 milligrams, you give a patient 1 milligram and you compare drug level, you give her 2, it's twice as much. You give her 4, it's twice as much as 2. And then that curve starts, instead of going like this, it starts going more like that. So 8 is not twice as much as 4 in a blood level. And by 8, the receptors are nearly saturated. So there doesn't seem to be a really outstanding physiologic reason, in my opinion, to go a lot higher than 8. And you can find hundreds of addiction medicine specialists that would argue with me on that. But we have tried every now and then with a patient that really was scared to drop down to 8, and they were just using us to temporize until they could find somebody else. So 8 is a rule we're sticking with because patients have rights. There's 14 other OBOTs and one other non-OBOT facility in our region, and they can do what they want. And if they think that that's not what they want to do, that's their right. Many patients come to us on benzodiazepines, and we will taper that over about a month. The literature on tapering is not outstanding. There's one group that says taper off about 20% a day. There's another line of thought is you need to take 4 to 6 months to taper off. You don't want to just stop it because of the risk of seizures. And you've got a group of patients that are actually benzodiazepine addicts, and they're also on Suboxone, and it takes a while to figure that out sometimes. When we started this, my predecessor, Dr. Welt, really started this program because patients would say to him, I would like to come off and no one will help me. So he decided to take the 8-hour course, and he decided to help them come off. And it was a let's try this. And I think here in Appalachia, we don't have a whole lot of resources. We have Band-Aids, baling wire, duct tape. We do the best we can. It was let's try this. And we've had outstanding institutional support. So the support team now includes my nurse, Claudia, who the patients know and respect her, and they know if they're having any issues, they can call her and she'll come to the phone and help them. We've got our case manager, Morgan, who many of you know because she's also a case manager that works with Pediatrics. Our patients have 3 counseling options. They could use the established, if they have a counselor, they're happy with the counselor, that's great. We have a Strongwell, this is a Navigator program. A Navigator program is a program that receives funding to help patients. In Strongwell's case, they'll help transport the patient to their doctor's office, to their counseling office. They'll check in on food security and So it's a whole program, and they are present in our office on Mondays. Our medication assisted therapy clinics are Mondays, so that way they can touch bases and make sure the counseling occurs. And then Dr. Lilienthal is our new behavioralist that as soon as the state of Tennessee blesses her application, she will be starting, and that is in the any day now phase. We have a lactation consultant, and she's relatively new, and we're getting to the point where every patient is offered the chance for lactation or other nutrition consultation. And of course, again, you got to get where the patient lives and recognize that they may live in an unsafe environment, have difficulty coming to the office to be seen. For monitoring, the controlled substance monitoring database is something that all physicians should check when they write for controlled substances. We check that every visit. We do a urine drug screen every visit. Interestingly, ACOG for screening purposes says you should not do urine drug screens on patients. And they do, however, say you should test all patients for HIV. Our HIV rate is 1 in 1,000. Our buprenorphine rate is 16%. So in our case, for our population, that's a guideline that we say that doesn't work for us. Recognizing, of course, that urine drug screens are not perfect. False positives occur, false negatives occur. It should not be the only tool. Taking a history, asking the questions are very important, but it's part of the tools. One of the fascinating things about taking a history for a screen is that, again, you have to get where the patient lives. So if I say to the patient, are you on any illicit drugs? And she's thinking, well, I'm on Suboxone that I'm buying from my friend, but that's the drug to treat drug addiction, so it's not illicit. So she says no. Are you on any prescribed medications? Well, it's not prescribed because she's getting it from her friend. So she says no to that too. And so then when the drug screen comes back, I might say, well, look, she lied to me. Well, no, she didn't. I just didn't ask her the right question. I need to just say, are you on tobacco, marijuana, Suboxone, Subutex, or any other substances? So I did not ask the question that was consistent with her world. We have multiple groups of patients with, in terms of urine drug screens. You got the group that is with the program from day one, never has anything in their urine drug screen that's other than buprenorphine. You got the group of patients that they're transitioning from polysubstance, takes them 3 or 4 visits, they get it right, buprenorphine only the rest of their pregnancy. And then you got a group that just really wants to do well, but just really can't. And for those patients, it's, we're doing the best we can. Would you like us to transfer you to an inpatient facility? Many of the patients have children. They feel their children wouldn't be safe if they transferred to another facility, and they don't want to do that. And we, certainly there are programs that would say, well, if you're not going to be with the program, then we're just going to have to discharge you. And that's not what we do. And I'm not saying it's right or wrong. It's not what we do. These patients frequently, they almost appear beaten when we first meet them because their life has been so difficult. And for us to say, well, we've given up on you, to me, would be so harmful that we don't want to do that. We will discharge patients for getting medications from some other doctor and not telling us about it. So we will do that. But the average patient that's trying and not getting it right, we are not going to knock her down. And there are times that, you got 8 positive drug screens for meth and 9, 10, 11 don't have it. So it does happen. So for our tapering program, we taper on average once every 4 weeks. We start at 8, 8, 6, 4, 2. There is a 2 milligram pill. So then we switch to the 2 milligram pill. And if the patient says, I think this is the best I can do, then that's where we stop. We'll ask her every time we see her if she thinks she would like to taper. She says, I think it's the best I can do. The answer is good for you for doing the best you can. For those who want to come off, then we break that pill up to a half a pill, a quarter pill, and then off. And there's that final "I'm off now" is very, very difficult for some patients due to the psychologic component. And then once they're off, we discuss naltrexone. And most patients, when they're off, are not interested in naltrexone. And that seems to be, "I'm off, I don't want to take some other drug." And so we've not had much luck in getting folks on naltrexone, and whether that's good or bad, it's hard to know. We certainly have had patients that have been off, come back in next pregnancy, they're back on again. So we have more work to do in figuring out that long-term piece. Now, the physician relationship is very important for this group of patients. Recognize the patient may have trouble with trust. And I think because I'm taking care of the whole patient, I'm taking care of her fetus, I think there's more trust more rapidly than a traditional MAT provider. And accentuate any positive. If she does something, congratulations that you're ready to taper. Congratulations that after 4 drug screens that were positive for meth, there's no meth this time. Good job. Whatever she's done right, accentuate it. And when they relapse, then you talk about what they learned, and you remind, patients will feel guilty when they relapse, and guilt can get in the way of progress. So one acknowledges the fact that they don't want to feel guilt again, but one also says this is common and you're going to get it. We do provide medication to help with their withdrawal symptoms. Hydroxyzine Vistaril helps with anxiety and sleep. Catapress, clonidine, that helps with some of the skin symptoms of cold, clammy skin. We occasionally use Thorazine, and I've never seen tardive dyskinesia, but I don't want to. So that's our long distance third choice. And marijuana is bad for a fetus. This is actually new data from late 2020 that patients who smoke marijuana throughout the pregnancy have newborns with smaller heads. But interestingly, if they smoked in the first trimester and they stop, then that effect is blunted. So it is a reversible, it's a problem that can be fixed by a patient coming off of marijuana. So, 2 years ago, I was ignoring marijuana because I figured we're working hard on what we can fix. Let's not overdo it for this patient, but that's no longer the right answer. So when a patient does relapse, and remember, there's all these other factors in the patient's life. We've certainly had patients claim to relapse and then admit later they didn't really relapse. They were given the extra medication to their partner. So just because a patient says she relapses doesn't mean that she really did. In our community, it's common that the patient would walk in and say, I'm on 8 milligrams. I relapsed. I think I need more. Okay, here's your prescription for 16. That's common. I just want you to imagine a patient that says, thank you for the 6 Percocets I've been getting a day, 6 Percocet 10s, but I'm still hurting. Can I have 12? And most of us would not do that. And I kind of think the rules are the same. If a patient has been on a dose for 5 months and she wants more, there's a problem. There's a problem that needs to be addressed, but it's not cravings. It's a problem that needs to be addressed. It's something different. So you ask what you learned from that relapse, you normalize it, you recognize that she may not be telling you the truth. And if the patient doesn't like what she has to say, you remind her that you have rights to autonomy. You may transfer your care at any time. Nobody's going to get mad. We'll be glad to take care of you obstetrically. That discussion, I call that the "this clinic isn't for everyone" discussion. It's there's the challenges to that discussion are patients should know their rights. On the other hand, they've had so many negative healthcare experiences that some of them will think I'm trying to get rid of them. So it has to be done with significant delicacy. And the links to domestic violence are significant, and partners will steal their medication. Partners will withhold it. We've talked about medication sharing. I've had multiple patients tell me how they got started on their buprenorphine addiction. Their partner said, why don't you go to one of those clinics, tell them you're an addict, they'll give you a prescription, we can sell it. And then they need to take enough to have someone on their drug screen, and then they're addicted. Now, on the other hand, you've got some outstanding partners and family members that are wonderful assets. These partners that want to be assets, they're in multiple groups too. There's a group of partners that are so frustrated, they'd like to help, but they've been watching their partner's addiction for many years. They've been lied to so many times. And why can't you just quit? And they're so frustrated, it becomes a barrier to them actually helping the patient cope with the addiction. And then you've got on the other end of the spectrum, the partners that are fully engaged and willing to help. One of the things that sometimes works is, you give a patient a prescription for a week, and 4 days into it, she decides she wants some extra, and she takes some extra, and because she's got the cravings, and then she runs out. So if you can have a family member dispense the medicine, that sometimes works, but then the family member or partner has power over the patient because they control the medication, and sometimes that doesn't work. Or the patient will wear out the family member. If you loved me, you'd give me some medicine. And so more often than not, it does not work, but it is one of the tools in the armamentarium. And then if the family member's in the room, the patient taking the extra, any relapses, no, because they don't want to admit to their partner. So you have to just, deal with that too. I'm going to show you a couple of patient experiences here.
I was doing it for a very, very, very long time, and then I found out I was pregnant. I didn't know what would happen with her, but I knew that, there was a chance that she could have some withdrawal. You have very little to go on. Just a little bit of help can go a long way. It made me sick to take that much. It's a very powerful drug. I know if I can do it, anybody can do it. Never thought that we would get here. I really didn't. She's amazing. She's so healthy. She's perfect.
I remember a 36-week gestation patient skipping out the door because she was so proud of herself. And to me, it's offensive that in the United States, the standard of care is that these women should not be offered the opportunity to feel good about themselves, to have pride in their accomplishments, to say, look at me, I've made some sacrifices for my baby. So we're wrapping up here. I continue to be amazed at how some patients will just all of a sudden get with the program. And there's just, there's another group that you think we're going to have a lot of success with her, and you never have it. So, a patient that every taper we're fighting, we're arguing, and then she walks in the door and says, I just decided to quit, I'm off now. Sometimes we doctors plant seeds, and then the next doctor waters it, and the next doctor may help the patient get where the patient needs to get. So we must never give up. So keys to success for us are to be non-judgmental, to promote that truthfulness, firm but nurturing, recognize the limits. The patient can only do what she's able to do. And the situation may be that if she's doing the best she can, I'm happy. So we try to get everybody down to 2 milligrams. But if I've got somebody that was on 4 substances and now she's on 6 milligrams and that's the best she can do, and I'm convinced that's the best she can do, I'm happy. If I have another patient that was on 2 milligrams and then took some extra and said, hey, listen, I want 4 milligrams and you're writing for it. And you've been on 2 milligrams for a month, but I need 4 now. Well, there's 14 other clinics in Johnson City. That's the answer to that patient, because I didn't feel like she was doing the best that she could. For ourselves, we need to remember the goal is NAS reduction, and we can measure that. So we're not, it's nice when we can get people off completely, but for our goal is NAS reduction. And if we're getting there, we're getting there. And then again, the list of frustrations here for physicians is significant. It's not the patients, it's the healthcare system. You would think that every time we save a baby from NAS, we save the state of Tennessee $43,000. People be knocking down our door saying, what can we do to help you succeed? Well, that is not happening. And, patients will go to the pharmacy to get their medication. They've been on this medication for months. Well, their PA ran out. Nobody told us. Patient can't get her medicine. Patient relapses. The healthcare system is not being terribly helpful. And then the incarcerated patients, we're working there. That's a group they'll be off completely while they're in the hospital, while they're in the jail, and then they'll get out and we'll see them 5 days later and they've already reached. So that's another area of potential growth. Wanted to shout out to Peds here. So we got Morgan working with both of us. We got Families Free has their pop-up party on in the mornings. We send some folks down there. Dr. Sketsy and others have the Baby Steps program. I think Dr. Johnson's got a grant application. Dr. Shaw got the comparison study. So I think that we're doing some trailblazing partnership here, and I think doing a better job handing off baby to Peds is something that we can all work on. So appreciate all you're doing to work with. Things to keep in mind, current behind any upcoming. NAS has lifelong consequences. If you're stuck in school, you can't get a good job, you're more likely to be in jail, you're more likely to commit suicide because you can't succeed. So long lifetime consequences. And it is, we need to recognize that organic medicine has been a predictor for several years. And
I think we lost him.
It would appear so. I guess hopefully he will return. I think we're towards the end of the talk. Looks like we have some questions over here. So if let's see if maybe he can rejoin here in a second. And if anybody has any other questions, if you wouldn't mind typing them in the chat, maybe we can kind of go through those. Should he be able to rejoin? Dr. Olsen, you're back.
hey there, am I back?
You are back.
All right, must have been hacked by people.
Though I believe that, oh, sorry. I was going to say
conclusions.
Sorry, your audio was cutting off a bit there. Brian, is there like a connection metric or?
Yeah, Dr. Olsen, you could go ahead and mute your video.
Oh, okay.
Turn off your camera. That might help your network a bit.
Yeah.
There we go. Not the microphone.
Dr. Olsen, if you could unmute your audio, I think we may be able to speak via audio at least.
Okay. All right, well, it says I can't start my video, so I'll be a disembodied voice. So the conclusion remarks I was in the midst of, but basically we can do better than we're doing. And appreciate all the help y'all have done in that process. And I'm ready to take any questions. We got a moment or two there.
Dr. Olsen, thank you for the talk. Sorry about the technical difficulties. I guess it's kind of a manifestation of the the times. But we do have a few questions that folks have posted over in the chat section. Would it be okay if I read those to you? And
Sounds great. That works.
All right. So Dr. Wood wanted to know, how do you get referrals to your clinic? Are they patients who are more willing to taper, or do you get referrals from the judicial system?
We're no referrals from the judicial system, but certainly once we take care of the patients, we then interact with the judicial system. So we have referrals from some of the office-based opioid treatment centers. So I think that is a real positive that, you know, there's some negativity in my view for the way buprenorphine is managed by some of our colleagues in the area, but there are also some that will say, listen, there's a person in town that's going to help you lower your dose, go to ETSU. We get, you know, most of the patients are our own patients. And when we have 16% of our patients urine drug screens are positive, there's not a shortage of patients. And a lot of it's word of mouth. So there's not really we're busy enough that we're not advertising, but we're glad to see anybody. There are a few of the local obstetricians referring to us as well.
That's great. And what about, is there a relationship between the dose of Suboxone and the severity of NAS that you would anticipate?
So the official answer from the American Society of Addiction Medicine is no, and you saw that graph. It would appear from what, and again, right now it's anecdotal. Our data is in nearly collected stage, but it would appear when we get people down to 2, we're hearing less from patients that my baby had NAS than we did when we were using 4 as our target. So I think we're going to find that lower dose has lower NAS, and if they do have NAS, it's less severe, but I can't say that scientifically.
Certainly makes intuitive sense. So, and then I had a question. You had touched briefly on the harms of like marijuana use during pregnancy with the reduced head size in the fetus. Do you currently view marijuana use as a relapse by your protocol? And do you expect that your protocol would change in the future, or should cannabis become legalized in Virginia or nationally and be treated similarly to, say, alcohol abuse or nicotine abuse?
No, we do not consider cannabis to be a relapse, and I think that's consistent with national standards, is that relapse will involve other substances, you know, meth and ecstasy and opioids and things like that.
So it's more something you would caution your patients to avoid.
That's right. Yeah.
Well, I think those are all the questions in the sidebar. So we really appreciate you coming and speaking with us. Dr. Saxena and Jay Shankar also express gratitude. That was an awesome talk, and thanks for coming out.
Well, thank you for having me. I enjoyed it.
Dr. Olsen?
Yes.
I did have one last thought. I
Yes.
really agree with you on that. We really need to celebrate these moms who get successful and who come off medication. So how would we know that, you know, is there a way you can share with our department when you've been successful in winning a mom and she's off and you really would like to make sure that they get home on time? Like, it would be great to be able to partner on that, like how, because I don't think we would necessarily know that information.
So right now it's in the ACOG flow sheet. If there's a better system, then I'm happy to work with you on a better system.
But do we get to see the ACOG flow sheet?
I guess it was my assumption that you could look over the mother's data, but I don't know what the current protocols are over there in the labor and delivery units. But so yeah, it sounds like we need to improve communication there.
I'm not sure. So, and I mean, we could maybe, we can talk offline, but I think, you know, it's even more important to support those moms who've truly come off and who are trying to stay off. And if we can help contribute to that, or even be more kind of understanding of those moms as they bring their babies into the clinic, I think it would be useful.
I agree with you. And from what I've seen from the patients, when you tell a patient you're normal or clean like everybody else, she really feels proud of herself. As she should.
And she should. So, all right. Well, we'll talk more.
All
Thank
right.
you.
Thank you. I appreciate that.
Okay. Bye-bye.
Thank you, Dr. Olsen.